We'll invite Dr. Prateek Nishant to start his paper, which is titled Opposite Clear Corneal Incisions versus Steep Axis Incision in Reduction of Total Corneal Astigmatism. Dr. Prateek, here you go. Your time starts now.
Thank you, esteemed chair. Ladies and gentlemen, good evening. This is my paper on comparison of efficacy of opposite clear corneal incisions and conventional clear corneal incision in reduction of total corneal astigmatism in patients undergoing phacoemulsification. I have no financial disclosures or conflicts of interest. Approximately 33% of patients undergoing cataract surgery are eligible for treatment of pre-existing astigmatism, and this is important to achieve spectacle independence. This is possible by manipulation of corneal incision parameters, not only the size, location, and shape, but also the number. There is an enhancement or flattening of effect of two opposite clear corneal incisions as compared to a single incision. Previous studies have documented this with the use of 2.8 to 3.2 millimeter keratomes. The efficacy of 2.2 millimeter OCCIs are yet to be quantified. The aim of the present study was to compare the efficacy of adding a clear corneal incision opposite to the main incision on the steep meridian versus performing surgery on the steep meridian alone in 2.2 millimeter phacoemulsification in reducing the pre-existing corneal astigmatism. This was a retrospective clinical study in 34 patients of senile cataract who underwent clear corneal phaco with monofocal non-toric posterior chamber intraocular lens. The eligibility criteria were as follows. All cases with disorders which could modify corneal astigmatism were excluded. After thorough preoperative examinations, the patients were subjected to telecentric keratometry of the IOL Master 700, and all surgeries were performed by a single experienced surgeon without limbal markings, using approximate limbal anatomical landmarks as assessed in the preoperative period on the slit lamp. The same type of monofocal aspheric foldable IOL was implanted in all the patients. Patients were divided into two groups. The group 1 comprised of 17 patients who underwent phacoemulsification with single clear corneal incision of 2.2 millimeters. And these patients had total corneal astigmatism of less than 1 diopters. In group 2, it comprised of patients, the same number of patients who underwent paired OCCI with the same 2.2 millimeter keratome after implantation of the IOL with the anterior chamber maintained by the OVD. These patients had total corneal astigmatism of more than 1 diopters. Post-op follow-up at 1 week, 1 month, and 3 months were done with a recording of the total keratometry by the same means. The results were statistically analyzed using the paired and unpaired t-test and chi-square test. Of the 34 eyes meeting the inclusion criteria, 17 were in group 1 and 17 in group 2, 11 men and 6 women in each group. The groups were comparable at baseline as regards to age, intraocular pressure, and axial length. There were no statistically significant differences. This is a table and chart showing that the baseline astigmatism in two groups was significantly different. However, both groups achieved significant correction of the total corneal astigmatism at the end of 1 month. The net change of astigmatism achieved at the end of 1 month for group 2 was approximately double as compared to that of group 1. The results at 3 months were comparable with the findings at 1 month. Approximately double correction of astigmatism was again achieved in group 2 as compared to group 1. These results were statistically significant. So astigmatism is a major cause of suboptimal vision after cataract surgery. Other existing modalities for treatment of corneal astigmatism concurrently or sequentially have their own disadvantages, including arcuate keratotomy, toric IOL, and excimer lasers. Steep meridian CCI as for phaco is recommended to reduce astigmatism, but single incision is insufficient if the astigmatism is beyond 1.2 diopters. OCCIs are self-sealing, pose no additional risk, and require no extra instruments and are effective. How effective? Previous studies have shown that variable correction of astigmatism is possible with 2.8 millimeter and 3.2 millimeter OCCI. This effect is not yet documented for 2.2 millimeter incisions in literature, which are more common nowadays. So varying incision lengths and amount of and type of pre-existing astigmatism preclude accurate comparisons with these studies. Moving on. In our study, a 2.2 millimeter keratome was used, which explains the smaller change observed compared to previous studies. And we observed that even a 2.2 millimeter OCCI has encouraging results by correcting mean astigmatism by about 0.57 diopters, even in the short term, that is approximately 1 month follow-up, and about similar 0.62 diopters in 3 months. The study is not without limitations of retrospective design, small sample size, and loss to follow-up. Long-term outcomes as larger sample are necessary to establish the quantum of effect that 2.2 millimeter OCCIs may have in correcting corneal astigmatism. To conclude, OCC has a reliable, easy, and cost-effective for management of mild to moderate pre-existing astigmatism with enhanced effect over single clear corneal incisions. These are my references. Thank you.
Thank you, Dr. Prateek. Before we move on, I'll just request the hall manager to ensure that the clock is ticking. It's sort of stagnant, and we couldn't keep count on the time that each presenter is. The clock should tick. Okay, start a countdown the moment the presenter starts presenting. Thank you. So the segment's open to judges for questioning.
Okay. So you said this is in a first study you say which is for a 2.2, but there are already other studies which have compared with a 2.25 incision at a single incision on an steep meridian.
Exactly,
so
sir.
what was that? You put both the incisions on an steep meridian or one temporal and another on a steep meridian?
Both incisions on the steep meridian on diametrically opposite. So this effect has previously been quantified using 2.8 or 3.2 millimeter astigmatism, but those were comparatively older studies when that size of a phacoemulsification was more popular. Now with the advent of 2.2 millimeter incisions, we now no longer use those keratomes. So,
but if you calculate the centroid value, 2.2 millimeter incision doesn't cause too much of an astigmatism,
exactly.
Whether it's in that incision or as an OCI both together.
Yes, I agree with that, sir. But actually, this study was done when to estimate whether you actually need a larger incision to correct that amount of astigmatism, or the quantum of effect is sufficient to say if a patient comes with a 1.4 diopter astigmatism, you correct it by 0.6 and he lands up with 0.8. So do you need a larger incision to correct the astigmatism below 1 diopter?
No, even if you consider the fact that the centroid does predict that a 0.2 is what is resultant of a 2.2 millimeter incision, since you did it on both sides, a 0.2 and a 0.2 make it 0.4, you said I think the resultant was 0.57, which is still acceptable. But there are two things that are lurking in my mind. I can't help myself but ask you. First is you did see it 1 month post-op. And there's going to be a drift after that too. So yes, this 0.57 might not stay as 0.57. It might lessen, it might worsen too with time. The other thing is you said that you have not marked the cornea preoperatively. Exactly. So how did you know that you are incising along the steep axis?
Okay. So the steep axis was reported by the IOL master report, and the operating surgeon, while examining on the slit lamp, approximated the limbal marking using the slit lamp slit angulation, and he identified a particular limbal landmark at that point. So what this leads us to believe is that marking is not all that necessary. You can even estimate your steep axis incise.
No. See, there are a lot of, I believe they're all done under topical, and we know that there's a lot of cyclotorsion that happens yes, once the patient is lying down on the table. So perhaps you can take it a step further, this study, and this continues as a prospective one instead of a retrospective one. And then maybe you can, because why I say this is because astigmatism is not a number, it's a vector.
Exactly.
So if you falter in wherein you have placed your incision, if it moves around 10 degrees, and the whole vector factor changes.
Right.
So you cannot conclude that it flattens the axis and causes an astigmatic flattening up to this extent with a 2.2.
Right.
But
exactly.
yeah, I mean, this is a good beginning, though I laud you for that. But maybe you can just take it further by marking it and ensuring that you are right bang on target when you are
exactly. And this prospective study is in fact in process with the markerless toric system Callisto. So here what has been done is to estimate a limbal landmark, and that is the classical way of doing this when we don't have a toric marker or a bubble marker or whatever it is. Now with cyclotorsion, that limbal landmark is quite less likely to shift because of the adherence at the limbus.
So it's always not possible.
I can
to
understand, sir. I can understand, but this is particular to this particular study.
Right.
I accept that is not the standard practice.
Thank you, Dr. Prateek. You stood up really well to the questions. Anything from you?